Before we go on to the next part, I want to try and give you a little bit of a feel for what these cerebrovascular events, TIA and stroke, are. I don't think I've got a way of, is there a pointer? No, I guess the pointer doesn't work. No, I don't, it's not coming up there. That's okay. So this slide gives you a little bit of an idea of the breadth and scope of what we call TIA or stroke. And unlike in the coronary circulation, where there's not that much different, there's not much of a repertoire, in the brain there's a lot of different ways that things can go wrong, manifesting as a TIA or stroke. And on the left you'll see a diagram of the blood vessels going up to the brain and down below the heart. And so when somebody has an event, a TIA or stroke, it can occur because there is a blood clot in the carotid arteries, and if you look at the middle part of the picture, there's some darkened area where there's narrowing of the carotid arteries. So that's an example of an atherothrombotic source, a narrowing in the carotid with an embolus going up into the brain. Or there can be a narrowing up in the brain itself, up at the top, something which is seen more in the Asian cultures than our own, but still seen to a reasonably large degree. And also, while we're up in the brain, there can be narrowing and occlusion or a blockage of very small vessels, the little tiny perforating vessels. And a very different clinical picture emerges if you block a big vessel up in the brain versus a thin vessel in the brain. And those are called arteriolar or lacunar events. So we've got the vessels, the large vessels which are involved, the atherothrombotic vessels occurring in the neck or up in the brain. There's the small vessels right up in the brain. Or down to the bottom to the heart, an embolus can come from the heart itself as a cardioembolic source. So when somebody has an event, we've got all these different places to chase down, and the treatment for these different etiologies is quite different as well. We anticoagulate people who have a source from the heart. We operate on people who have a source from the carotids. And for atherosclerosis and lacunar disease in the head, we chase all the risk factor management. We hit them heavily with statin drugs and antihypertensive drugs and antiplatelet drugs. So there's a different response depending on what caused it. The other thing about it, what I'm going to be calling acute cerebrovascular syndromes this afternoon, which encompasses stroke and TIA, is to get this notion that TIA really is the same as stroke, and it's an unfortunate thing that that designation was ever applied. So technically a TIA is a reversible ischemic event where the symptoms and signs have disappeared after 24 hours. But now in the world of MRI and lots of new imaging capabilities, we know that many TIAs are actually strokes because there's been permanent damage. So the whole concept of what is a TIA and what is a stroke is sort of disappearing. And in fact, if you look at this graph here and think of those three different courses, there's a red one at the top. That's our hot stroke. It comes in on the left-hand side there, quite severe. It even gets worse over time and keeps going at that high level of severity. Then the second one is a bit of a warm stroke. That's the orange-colored one. It starts off quite severe and then drops down and flattens out, and for that period of time you would have called it a TIA. But then it picks up again at about 24 hours and becomes severe. So depending on where you walk in on this person, you may have called it a stroke if you saw them at 36 hours and they'd stayed at home. Or if you were in the emergency room and they'd come in after 2 hours, it would have been a stroke at that point. Or if you were looking at them at 24 hours, it would have been a TIA because it had gone away. So really it passes through many diagnostic designations depending on the timing. And then the third one, the blue one, the cold stroke, it starts off severe and goes down over time. And over the course of a few days, it goes to zero. So you might see it a couple of weeks later and say it was a TIA. But actually, if you'd examined them at 24 hours, there was still a little bit of severity there. So it would have been a stroke. So just to make the point that you can't put too much weight on this TIA and stroke designation. And really, the dividing line comes between the mild stroke and TIA, which are ambulatory and we can manage in a clinic, and the severe stroke, which needs hospitalization and nursing care because of the dangers of aspiration and DVT and all of the other medical consequences of stroke. The other thing which complicates the picture is that when the brain misfires, malfunctions, it may do it for many reasons, and stroke is not the only one. And here I've got some pictures showing some of the visual phenomena that have been published about migraine. And a lot of what we see in our TIA units is in fact migraine, because part of the brain is momentarily disabled because of a metabolic process here rather than an ischemic process. Clinically, we distinguish the two because when migraine kicks in, it activates the brain. The brain is overactive. When stroke is the mechanism, it's underactive. But still, we have on occasion been fooled. This is a friend of mine who came into the Jubilee Hospital with migraine, and what we see at the bottom left-hand corner is a white hole, which is his stroke. And it also shows us at this point that the value of the new sophisticated imaging, in this case an MRI, which can really help distinguish in some cases episodes which are unclear to us, where somebody had some symptoms and they've gone away and we don't know what they are. In many instances, a diffusion-weighted image, this MRI image, can tell us that there in fact has been some damage, and it does so in a very sensitive fashion.